Efficiency for me means that we use the resources that we have in a best efficient way, not to be stuck in the old way of thinking or working. I think that within oncology, I can only talk for Sweden. Unfortunately, we are convenient of doing as we have always done. And maybe we need to be challenged more and think outside of the box. So the convenience that I'm talking about is convenient for the system. And it's not always what is the best for the patient, and it's always not what is the best for the individual care provider also. So the system is very rigid, it's not flexible. The first thing to start with is to have a clear definition of efficiency in cancer care. We need to perform tests and errors, the trials, so we need to test a new working method. We need to rethink, because we have today care processes that are really not personalized. They are in a group level. So as long as our care processes within cancer are based on group level, but then we will always miss this efficiency that you and me are talking about. We need first of all, to know how we are doing today, talking about outcomes, we need to understand who is measuring what between the countries. To benchmark the outcomes between the European countries, it has not been done so properly. There are few countries there who are doing that. Definition of efficiency is different between hospitals within the same country also. It's not always that one hospital has more sick patients compared to another hospital, because that's usually the argument from the leadership, the management, that we have a worse outcome here because we have more sick patients, or for example, or we don't have that or this and that. So there are a lot of speculations around why they don't have a better outcome compared to another hospital. So what I think it's needed, really needed, it is to develop a risk adjusted models, so that we actually can compare the outcomes, so we can really compare apple with apple and pear with pear. So that argument that I have more sick patients compared to your hospital, that shouldn't be a part of the argument. You need to have a robust model for this to compare the outcome, and to also answer the question about efficiency. So the first outcome, I think, is the cancer-specific mortality, because to look at the overall survival in general, since many of our patients are actually long-term survivors, so you could adjust the model for that, of course. To really answer the question, I think it's better to look at the cancer-specific survival. The second outcome that we are looking at in our research is both short but also long-term side effects. And then, of course, the patient-reported outcomes, if those variables exist. It's important that they are responded at the specific time point. So we really can compare apple with apple, because if a patient has answered those questions directly after a diagnosis versus somebody who has answered after 10 years of diagnosis, difference between these responses. So it's important to measure it at the same time, or compare those at the same time. So I think education to general population is something that we need to focus on also. I know that in the EU Cancer Plan, focus is a lot about prevention, but within that prevention also comes education.